Assalamu alaikum. A very good morning to everyone. I hope you are all doing well and enjoying the conference. We are joined this morning for a very wonderful event, Endohub, for the Endocrine Fellow across the country. This program has been started by the former President, Associate Professor Dr. Ibrar Ahmed, who is working as consultant endocrinologist in Lady Reading Hospital, and it has been very good for the fellows, encouraging fellows to participate in this event across the country from Brisbane Hospital, bringing interesting cases and rare cases for knowledge as well as presentations and giving them skills to move forward. So without any delay, we will start our conference officially, our session officially with a few verses of Holy Quran. So kindly pay respect for a few verses of Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم آمن الرسول بما أنزل إليه من ربه والمؤمنون كل آمن بالله وملائكته وكتبه ورسله لا نفرق بين أحد من رسله وقالوا سمعنا وأطعنا غفرانك ربنا وإليك المصير لا يكلف الله نفسا إلا وسعها لها ما كسبت وعليها ما اكتسبت ربنا لا تؤاخذنا إن نسينا أو أخطأنا ربنا ولا تحمل علينا إصرا كما حملته ربنا ولا تحمل علينا إصرا كما حملته على الذين من قبلنا ربنا ولا تحملنا ما لا طاقة لنا به واعف عنا واغفر لنا وارحمنا أنت مولانا فانصرنا على القوم الكافرين.
Jazakallah. For this program, we are having a panelist, our renowned endocrinologist across the country. I would like to introduce them to the stage and invite them. Professor Dr. Abdul Jabbar, please, sir, join us on stage for this. Associate Professor Dr. Ibrar Ahmed, sir, please join us on stage. Consultant endocrinologist Sadiya Salman, madam, please, if you are here, join us on stage. Consultant endocrinologist Dr. Gawar Khan, sir, please join us on stage. We are having a list of participants. I will enlist their names, and then we will call them accordingly and start the program. Dr. Arfa Fatma, Dr. Muhammad Sami, Dr. Ayman Malik, Dr. Sajad Ahmed, Dr. Sonam, and Dr. Asri Ahmed. So one by one we will call them and we will start their presentations accordingly when the judges are ready. The first participant of Endohub, I would like to invite Dr. Arfa Fatma to come on stage and please start your presentations.
Assalamu alaikum. I'm Dr. Arfa Fatima, Earby Endocrinology Fellow from Aga Khan Hospital. So the case that I'm presenting today is a diagnostic dilemma. My patient initially presented in September 2019. She's a 25-year-old female, married for the past 4 years, resident of Karachi, who presented for the evaluation of secondary amenorrhea, which was present for the past 4 years. The patient had achieved menarche at the age of 14 and had reported that her cycles were regular, with flow occurring every 28 days. For the last 4 years, she was experiencing occasional withdrawal bleeding with progesterone-only pills. She also reported increased growth of coarse, thick hair on her face, neck, and chest during this period. There were no complaints of acne or changes in her voice quality. She had no complaints of headaches, galactorrhea, vision changes, violation of abdominal striae, change in her thirst or urination patterns, heat or cold intolerance. There were no changes in her appetite, sleep, or bowel habits, or any history of mood disturbances or any stress. Her weight had been stable, and she had never conceived during this period. Her past medical history was significant for hypertension, and her parents also had this, and her sister also had a history of PCOS. In terms of her medication history, she was only taking amlodipine 5 milligrams daily and was not on any other medications. Her physical examination showed normal vitals with a raised BMI of 27.3 kilograms per meter square. Hirsutism was also present with mild temporal baldness. The thyroid gland was not palpable. There were no violaceous abdominal striae, acne, or proximal myopathy. The Ferriman-Galvez score was between 18 to 20, and she has clitoromegaly. So her workup done over the past 4 years, from 2016 till 2019, showed persistently raised testosterone levels. The recentmost levels are 417 nanograms per DL, done in February 2019. She had normal DHES levels and low LH-FSH levels. Thyroid function tests, prolactin levels, and insulin levels were normal. The workup also showed persistent polycythemia. A transvaginal pelvis ultrasound was done in February 2017, which showed an enlarged right ovary with a simple cyst measuring 3.5 into 3.4 centimeters with no solid element or septations. The left ovary had a solid echogenic area arising from it, measuring 5.7 into 5.4 centimeters. So this was a young female with hyperandrogenism and secondary amenorrhea. Her workup done on this clinic visit showed raised testosterone levels and 17-OHP levels of 526.9 and 10.93 respectively, with low LH-FSH levels and normal DHES levels. A CT pelvis with contrast was done during the same period, which showed an ill-defined heterogeneous enhancing lesion involving the left ovary, measuring 8.7 into 5.2 centimeters, and this mass was adherent to the sigmoid colon, abutting the fundus of the uterus and the right ovary. So this patient was diagnosed with an androgen-secreting left ovarian tumor. She also had persistent polycythemia, and phlebotomy was done preoperatively. So on 13 November 2019, laparotomy and left salpingo-oophorectomy with excision of the right paratubal cyst, infracoligamenectomy, and a bilateral pelvic lymphadenectomy was done. The intraoperative findings showed a left ovarian complex solitum cystic mass measuring 10 into 8 centimeters with features consistent with a steroid cell tumor. The capsule was intact. The right para-ovarian cyst showed a serous cyst adenofibroma. Post-operatively, her hirsutism was better, and she had spontaneous menstrual cycle in March 2020 with light flow. There was normalization of her testosterone and 17-OHP levels. However, the patient was lost to follow-up after March 2020. She then presented in November 2024 in the endocrinology clinic with persistent complaints of secondary amenorrhea. There were no changes in her voice or in features of masculine habitus. She had withdrawal bleeding once in August 2024 with light flow on a progesterone-only pill. Examination showed an increased BMI of 30.9. Hirsutism and clitoromegaly was still present. Her Ferriman-Galvez score was between 18 to 20. The workup done at that time had raised insulin levels of 41.9 with raised testosterone levels of 199 nanograms per DL. So extensive workup was then advised, which showed raised testosterone levels of 202 nanograms per DL, raised 17 OHP levels of 6.8 nanograms per DL, and raised free androgen index of 44.36. Her FSH, LH, and estradiol levels were normal. An ultrasound transvaginal pelvis was done, which showed an intramedullary thickness of 10 mm, with normal appearing right ovary and no adnexal abnormality. So what was the cause for the raised androgen levels in this patient? Did she also have an underlying non-classic CH with this ovarian tumor? So the patient was advised lifestyle modifications. Glucophage 500 milligrams twice daily was started, and the plan was made to get an ACTH stimulation test for 17 OHP. The levels of which were reported as 14.95 nanograms per ml, so they were significantly raised. Glucophage was increased to 750 milligrams twice daily 5 milligrams of prednisolone was added, and dihydrogesterone 10 milligrams twice daily was started. However, when the patient followed up after 2 months, there had been no reductions in her testosterone or 17-OHP levels. The dose of steroids was increased to 7.5 milligrams of prednisolone daily, and she was advised to follow up in 6 to 8 weeks with repeat workup as well as imaging studies. However, the patient was non-compliant, and she followed up after 3 months with no reason to work up, and she was not taking any of her medications. At this point, she was started on dexamethasone 0.5 milligrams at night, medroxyprogesterone 10 milligrams daily, and ACTH and DHES levels were advised. So this is an overview of this patient who had secondary amenorrhea for the past 9 years. So the possible differentials that we had: firstly, does she have non-classic CH with a coexisting ovarian steroid cell tumor? Features favoring this are the fact that she remained amenorrheic post-procedure, and she had raised 17 OHP levels after her ACTH stimulation test. The second differential is there a recurrence of her ovarian steroid cell tumor? So the features favoring this are that there was rapid reduction of her testosterone and 17 OHP levels post-surgery. When she was started on steroid therapy, there was no response in terms of her testosterone levels. Secondly, she did have a transvaginal ultrasound, but small tumors may be missed, and the better modality imaging and extensive workup may be needed if the patient still has symptoms of an ovarian steroid cell tumor. So after doing extensive literature review, I came across case reports which talked about how a patient may initially be diagnosed with non-classic CH and started on treatment, and there may be non-response to this treatment, after which further workup may lead to a diagnosis of ovarian steroid cell tumor, which may masquerade as a non-classic CH. So in this specific case report, the patient had biochemical clinical features of hyperandrogenism. There was initial response to steroids therapy. Her ultrasound imaging were unremarkable, but later on, when there was no biochemical improvement in this patient, a CT scan was done, which showed a 10.4 centimeters solid-eyed ovarian mass, and this was later diagnosed to be a steroid cell tumor. This case report is also similar in terms of an ovarian steroid cell tumor masquerading as steroid unresponsive CH, but in this case, the imaging, which includes ultrasound, CT, and MRI, were all normal, and the patient eventually required bilateral selective adrenal venous sampling, which diagnosed her tumor. This report talks about how there may be recurrence of an ovarian steroid cell tumor. So the further management for our patient are to get ACTH and DHES levels, depending on which we will decide if she has an adrenal source of hyperandrogenism or an ovarian source, and then we would go for further imaging accordingly. In case of negative imaging, then ovarian or adrenal venous sampling would be the next option. Urinary steroid profile is another thing that can be done, but it's currently unavailable. Thank you so much.
Very well presented and interesting case and complex. Why the CT scan and MRI is still pending?
Sir, it is to be done. The patient had actually not followed up for nearly 2 months. So when she came to us in May, we have advised her to get DHES, ACTH levels, and then an imaging has also been advised. So that's to be done.
So based on the new ACTH and DHES sulfate level, what will be the next step?
So sir, if the levels are normal, then we would go towards the fact that she may have a ovarian source for her hyperandrogenism. So we would go for MRI pelvis in that case.
And during the CAH workup when you were doing, did you do ACTH level?
ACTH levels were not done at that point.
Why was it not done?
Yes, that was something that should have been done.
Because it's very difficult to differentiate if you don't have those levels, especially in a case where they are already diagnosed and surgery has been done for the ovarian tumor.
Most of the time in non-classical CH, we don't use steroids, but you use steroid in this patient to begin with the diagnosis of non-classical CH.
Yes, we did.
This is really the treatment to begin with in the cases of non-classical CH?
So we were trying to see if there was any suppression of her testosterone levels with response to that. So that was the initial reason. And she had persistent secondary amenorrhea, there were features of hirsutism. which were bothering her.
And at that time, you give her progesterone. She bleed at that time?
She did not.
Because her endometrium was thick at 10 millimeter, but she did not
Yes,
bleed at that time.
No, her progesterone was also changed to medroxyprogesterone, but that's to be checked if she bleeds after that.
Was any other treatment given for hirsutism in the light of high testosterone and patient symptomatic and suffering?
Not after 2024.
What will be the recommendation in a PCOS or ovarian androgen secreting tumor? Besides giving steroids, what else you should have considered?
Antiandrogens like spironolactone can be started.
So again, the same question, so many years, why was it not done?
So, sir, she was actually not on follow-up for the past 5 years. After 29...
No, that's not the case. You gave steroids. You didn't say she's not on follow-up, so I will not give steroids.
Right.
So the question is, did you prescribe and the patient didn't take, or you didn't prescribe?
At this point, we know.
You didn't prescribe.
During the whole process, was her family was involved in this whole
Yes,
sequence?
she was always there with her husband in her visits. Okay, thank you so much.
Thank you, Dr. Arfa Karim, for your participation and presentation. Our next candidate is Dr. Mohammad Sami, who is working as fellow endocrinology, Hyderabad Medical Complex, Peshawar. Dr. Mohammad Sami, please come on stage and have your presentation.
Hello everyone, I'm Dr. Mohammad Sami and I'm fellow endocrinology at Hyderabad Medical Complex, Peshawar. And today I'm here to present my case at Endohub 2025, and its case was very much interesting and was challenging for us. So let's start. So in this presentation, we will go through the patient history first, then we will go to the laboratory findings, then we will go to the working diagnosis and discussion, and then we will have the final diagnosis and then the treatment and patient monitoring plan. So the patient history is the male patient, age 55 years from Banu district, known case of type 2 diabetes mellitus, presented to us with the chief complaints of diabetic foot ulcer from the last 2 months, anorexia from the last 1 month, and letharginess from the last 1 month. So according to the patient attendants, he has a type 2 diabetes since 2015 and was using having depressive symptoms for which he was using antidepressants. He developed right diabetic foot ulcer on the plantar aspect 3 months back, post-nail injury, and have the poor glycemic control due to the non-compliance to his diabetic medications. But from the last 1 month, he was having symptoms of generalized weakness, anorexia, and letharginess that was not associated with other physical symptoms, including vomiting and diarrhea. So now let's talk about the past medication history. So he's a type 2 diabetic patient. He was using insulin and oral anti-diabetic medication. For depressive symptoms, he was using escitalopram and quetiapine. And there was no history of medication like laxatives, diuretics, antibiotics. And also note that he has used of the unknown street drug. So according to personal history, he was non-smoker, non-alcoholic, he had no allergies, and also I'm once again emphasizing he was user of unknown street drug. So the family history was negative for any kind of electrolyte imbalance or other form of endocrinopathies. So let's come to the examination. The patient was fully conscious, looks ill with dull facial expressions, vitals were stable. Abdominal examination, cardiovascular examination, respiratory examination, and CNS examination were unremarkable. And the diabetic foot ulcer was dry, non-healing on the plantar aspect of the right full heel region with no signs of infection or inflammation. Now let's discuss the investigation. So the complete blood picture, liver function test, renal function test, CRP, albumin, urine RE, stool RE, thyroid function test, lipid profile were all normal, and the fasting blood sugar ranged in the 160 milligram per deciliter with HbA1c of 8.4%. The chest X-ray was normal, ultrasound and echo was also normal, but the main concern was the sodium of 106 with the potassium of 4.2 and chloride of 101. We calculated the plasma osmolarity that came out to be 254, that was quite low, urine osmolarity of 300 milliosmol per kg, and urine sodium of 30. And 9 AM serum cortisol done twice came out to be 12 microgram per deciliter. So we have, now the case is very much simple. Hyponatremia, the serum osmolarity came out to be the low, so it's called the hypotonic hyponatremia. And then we have to assess the volume status to further differentiate the differentials. So as you know, as I already said, the vitals were stable, so volume status was normal. So the patient is in the euvolemic state. So we have to make the diagnosis from these differential lists. So, a working diagnosis was made in the form of hyponatremia due to SIDH, as you already know. There was no history of surgical history. The thyroid TFTs were all normal. There was no history of any beer intake and no history of thiazide diuretics or ACE inhibitor intakes. And he was not already doing any kind of strenuous exercises. So let's discuss. Our observation suggested that the patient was on chronic antidepressants, and that's why we have called it as a hyponatremia due to SIDH. So we started him on fluid restriction and discontinued the antidepressants. After all this treatment, patient didn't respond well, and the sodium just improved from 106 to just 111. And even after 2 days, sodium just increased to 112 with no improvement of the symptoms. This raised our concerns. So the reconcentration was made and the patient was started on IV sodium replacement in the form of normal saline. And again, the detailed history of the drug use taken by the patient and attendants, and the painkiller that he used before admission was asked to be brought by the relatives for the further evaluation. So what was the dilemma in this case? So if the patient was having SIDH, then why the sodium was not corrected after fluid restriction? And there was a worsening of sodium level. Number 2, patient was in stress state, admitted since 1 week. Why this serum cortisol level is low with a value of 12 done twice? And number 3, the normal saline infusion increased the sodium levels to just 118 after 48 hours of the correction, which remained around 120 even after 2 days of continuous normal saline infusion. So for answering all these questions, we did the paired ACTH and serum cortisol and found both ACTH and cortisol to be low, as he was having in the stress state, so the cortisol needs to be in the double. So steroid shot was given to the patient and serum electrolytes was repeated, and surprisingly, the sodium level jumped to 126. And MRI brain that came out in this time period came out to be normal. So the treatment was started with a hydrocortisone, and stress dose was also advised, and serum electrolytes was monitored weekly and then monthly. So these findings changed our mind to search for the cause of it, and the street drug that the patient was using as a painkiller before arrival was sent to the laboratory for further evaluation. And the laboratory reports, as being shown on the right side of this picture, was the prednisolone, the Hakimi medication containing the steroids, and that caused the adrenocortical insufficiency leading to chronic hyponatremia. So the final diagnosis was made as a chronic hyponatremia due to adrenocortical insufficiency. So now, just quick review of the chronic hyponatremia. As you all know, sodium level of less than 135 is called hyponatremia, and chronic state is called when abnormally low levels for longer than 48 hours. And now you can see from this picture again what we have done. Hyponatremia, we have done serum osmolarity that was quite low. Then we called it as a hypotonic hyponatremia. Then volume status was checked, and euvolemic status, the SIDH diagnosis was made wrong, and the adrenocortical deficiency was made right. So these are all the treatment algorithm. We follow the treatment algorithm when we have to rule out the cause and then to treat the patient accordingly according to the cause. Now there are different other case reports, like in this case we have seen the secondary adrenal insufficiency presented as hyponatremia, and basically this case the cause was the pituitary macroadenoma, but in our case that was the steroids. This is another case that is the secondary adrenal insufficiency presenting as severe hyponatremia. This case really coincides with our case. So we'll give you the links at the last. So what was the conclusion of our study? So from our findings from this case, it is very obvious to fully investigate the patient, take proper history, don't ignore any laboratory findings, and hyponatremia should be taken as a serious condition. So based on all these facts, we have reached the proper final diagnosis. So thank you all of you for listening, and thank you so much to be present here. Thank you.
Thank you. What is the criteria for the diagnosis of SIDH? Can you diagnose SIDH in somebody who has got low cortisol?
Actually, the SIDH have its own main criteria, and basically a diagnosis of exclusion.
No.
So when we...
Yeah, what is the criteria? You should have excluded cortisol and thyroid problem and diuretic use. In this patient, you checked cortisol 2 times and it was low.
Yeah. Yes, it was low.
You didn't act.
No, it was around 12. Like in our laboratory, there was written like we have the normal range of cortisol at 6 to 12. So we, as a normally fellows, all take it as a normal.
No,
so why
in a case who has got hyponatremia and cortisol is 12, you disregard it?
No. So why we disregarded? Actually, we have to thoroughly investigate the patient
first. Why didn't
first.
you give a steroid?
No, not before. We'll justly do all investigation first. Steroids is, listen, it is a very important question. Steroid is not basically a good drug for any patients. First, we have to make exclusion that if we can save the patient from getting steroids all lifelong, So for bothering the patient from these getting steroids, we have to done investigations, and the symptoms were not even coinciding with the steroids. He
Not
should have.
symptoms, the sign of hyponatremia, very strong.
Yes, he was having anorexia, letharginess, and no even signs of Cushing syndrome, like strious abdomen, any buffalo face.
Anorexia is a sign of steroid deficiency.
Yeah, it's a sign of steroid deficiency, but sir, even the fever patients present with anorexia, so we can't ignore it. We can't give fever patients a steroid shot then.
Second question before I give to my team. When you checked, his cortisol was low and ACTH was low. So why did you do the pituitary MRI?
Even before, yes, this is a very main question. As I have already shown the case report here, there was a case of secondary adrenocortical insufficiency that was due to the pituitary macroadenoma. That was causing the non-functioning ACTH, मतलब ACTH उसमें low था. So अब हमने जो है ये केस मैंने इसलिए ही दिया है कि देखो MRI आपने करना है, you have to exclusion. अब आप बाहर की patient की drug पे अब ये नहीं कैसे steroid ली है. Maybe something is in the brain which is causing the suppressed ACTH and HBXs. So for this we have all done this. Thank you.
ACTH stimulation test क्यों नहीं किया? It was 12 AM cortisol. It was 12.
ACTH stimulation test अब बाहर से वो ले रहा था, एट्रोजेनिक था, ठीक है, पेशेंट बाहर से ले रहा था, आपके पास cortisol ACTH आ गया.
You document it at the end. The drug came to know. You documented it in the last, but not in the beginning. That was a painkiller for you.
एक सेकंड, पेन किलर वो लाया नहीं था अपने साथ. अब पेशेंट की मैं इसलिए कह रहा हूँ कि पेशेंट हिस्ट्री इसलिए इंपॉर्टेंट है कि पेशेंट हर चीज़ अपने साथ नहीं लाता कि मैं घर में क्या खा रहा हूँ. सो हमने जब देखा कि हम डायग्नोसिस में नहीं पहुँच रहे, तो भाई आया ये बंदा ऐसे कौन सी ड्रग ले रहा है. सो फॉर विच हमने कहा कि आप जो पेन किलर ले आओ ज़रा ले आओ कि हम लेबॉर्ट्री सेंड कर दें. उसमें भी आने में 1 वीक लगा है.
Okay. Do we give normal saline in the management of hyponatremia? Normal saline? 0.9%?
Chronic hyponatremia. My case was a chronic hyponatremia. आपने अब सोडियम लेवल्स तो करेक्ट करना है. अब जब तक आप डायग्नोसिस पे नहीं पहुंच पाते हो, you have to improve the patient's symptoms first. For the chronic hyponatremia, it's a normal saline, and for the acute symptomatic hyponatremia, we give 3% normal saline.
Okay.
जी.
What was the stress? Patient was vitally stable and other things like that. He was conscious, alert. So what was the level of stress that was causing him to, you were saying the stress was the reason, so we couldn't get the double cortisol. So what was the level of stress? Was that this much?
From the last, in the beginning, I have just written that he was admitted from the last 1 month. Patient जब वहाँ पे हो जाए, stress state हो जाती है, hospital में admission होना. And also in the home, जब वो घर में भी था, तो वो इसके 3 months ये symptoms थे. So we take it as a stress state. Okay. Thank you.
How much common is hyponatremia in secondary tertiary hypocortisolism? And did you give this patient fluorocortisone?
No, hyponatremia is very much common. Even endocrinology people get calls from all over the departments that patient is hyponatremia, and we just usually see RBS level first. हम RBS देख लेते हैं, बाकी चीज़ों को इग्नोर कर लेते हैं कि RBS आप कंट्रोल करो, हाइपोनाट्रीमिया खुद ही ठीक हो जाएगा. सो द केस इज़ वेरी मच लाइक कॉमन हो रहा है आजकल. हमारे वार्ड में तो बहुत कॉमन है, इवन बाकी फेलोज भी एग्री करेंगे इस बात से कि हाइपोनाट्रीमिया कॉमन है. फ्लूरोकॉर्टिसोन की इसलिए नहीं नौबत आई, पेशेंट का BP बिल्कुल ठीक था, एंड सेकेंडली द सोडियम लेवल जंप टू 126. सो इफ यू आर गेटिंग द नॉर्मल वैल्यूज विद जस्ट हाइड्रोकॉर्टिसोन, why to add other drug and why to put a burden on the patient then? Thank you. Thank you.
Thank you. I think it's a good learning for the audience that if you come across a patient like this and you randomly check cortisol, you don't have to worry what the patient is taking. The most likely situation is this is exogenous steroid. It is not endogenous steroid. Cortisol level is low, sodium is low. You must presume it's exogenous. If you want to treat this patient, there is no harm giving after taking the blood sample steroids. And in this case, they would have sorted the case in the very first few days rather than waiting for so long.
Thank you, Mohammed Sami, for your participation and excellent presentation. Our next participant is Dr. Ayman Malik, who is fellow endocrinology in Capital Hospital, Islamabad. Ayman Malik, kindly come on stage.
Thank you so much for having me here. First of all, I would like to thank Pakistan Endocrine Society for providing this esteemed platform to us to present our cases. My case is when menstruation refuses to return, and this is a case of this is a very challenging case of amenorrhea in a young girl from rural Pakistan. I am Dr. Ayman Malik, fellow endocrinology from Capital Hospital, Islamabad. So the demographics are, my patient is a 24-year-old female unmarried resident of a periphery of Rawalpindi, and she presented to endocrine clinic first time in October 2019 with the complaints of galactorrhea and secondary amenorrhea. She is the fourth child of consanguineous parents. The birth and developmental history was normal, and her menstrual history is that she menarched at 13, reportedly after some surgical procedure that was probably it was some hymenectomy or other gynecological procedure, but the record is unfortunately not available. Initial cycles were regular for 6 by 30 days for 1 year. Then she suffered from amenorrhea for almost a year. She took treatment from some local gynecologist, and the menses restarted, but they were irregular and with spotting. The amenorrhea then resumed at age 16, and that persisted along with abnormal breast discharge. The galactorrhea was initially yellow, then milky, and it was profuse, and out of embarrassment, she has to change about 5 to 6 shirts daily. And the galactorrhea and amenorrhea was associated with cyclical abdominal pains and headache. The headache was just mild to moderate. And she denies any history of anosmia, visual problems, excessive exercise, or psychological stress, excessive weight gain, loss, polyuria, polydipsia, any acne, hirsutism, hypertension, radiation exposure, any learning difficulties, or chronic medication intake. So on examination, she also has no family history of any such complaints in her mother, and she was the only sister. Her general physical examination was normal. She had a BMI of 20, heart rate normal, no evidence of any acne, hirsutism, stria, hyperpigmentation or vitiligo, or no dysmorphic features. Her tenure stage was breast and pubic hair 5. Genital examination was normal female genitalia and orifices. She has normal visual fields by confrontation method, normal fundi, and rest of the stomach examination was unremarkable. So we investigated the case, and she had prolactinemia, hyperprolactinemia. It was 97. Rest of the profile was absolutely normal. Normal LH, FSH, estradiol, testosterone, free T4, TSH, and ultrasound abdomen and pelvis was also normal. Her MRI brain was also normal, and that was done with pituitary protocol. So a working diagnosis of hyperprolactinemia, idiopathic hyperprolactinemia was made, and she was managed with cabergoline, and regular follow-ups were advised. Disease course. So prolactin levels started declining, and the galactorrhea settled in few months, but menstruation did not resume. For restoration of menstruation, progesterone challenge and sequential hormone therapy was done, but she never had any withdrawal bleed despite of treatment for 2 consecutive years. And out of the family pressure and out of frustration, she contacted some local gynecologist near her village and had undergone some surgical procedure, and the record of which was again not available or was deliberately not shown to us when she was again admitted to us in 2013 with complaint of persistent amenorrhea. There was a history of surgical procedure this time, and on examination, the new finding was that she was having phenycyl incision on her lower abdomen. The rest of the examination was unremarkable. She was further evaluated with hormonal profile and pelvic imaging to rule out any other cause of persistent amenorrhea. So the further evaluation showed low AMH but normal FSH estradiol. Her MRI brain with pituitary protocol was repeated again after 2 years, and that showed tiny microadenomas. And MRI pelvis was normal with uterus and ovaries, and mild free fluid was present in the pelvis. So we further managed her with the cabergoline and hormone replacement therapy, and compliance to medication was ensured because we had a doubt that the hormonal axis is normal, but still she is not menstruating. So either she is missing her doses, or maybe she's not telling us that she is taking the medications, or she is having the menstruation. So we involved her mother and her family to ensure the compliance and keep an eye on her that she is taking the medication and she is menstruating or not. So we had the psychiatry evaluation also, and we involved the gynecology team also, because it was a diagnostic challenge for us that why she is not menstruating despite of the normal prolactin levels and the hormonal axis. And we advised the follow-up. Then she complained, she was admitted again in 2025 with persistent amenorrhea and no withdrawal bleed despite of the hormonal replacement therapy and the repeated progesterone challenges. Marriage concerns arising from the amenorrhea, domestic issues, and she was suffering from the severe depression. This is the summary to the hyperprolactinemia in 2019. Then prolactin levels started declining. We gave her the treatment with Dostinex, 935, Proguanova, and 2021 she underwent some surgery. So the levels are normal. In 2023, the new finding that we received that her AMH started declining. Her ultrasound was normal, MRI pelvis was normal, but she was having some fluid in the pelvis. In 2024, microadenoma. In 2025, this time we confirmed the trend of AMH that was still low. So this is the neuroimaging from 2023 that showed the microadenomas. Then pelvic imaging that showed normal uterus, normal ovaries, still she is not menstruating and had some free fluid in the pelvis. This is the summary that galactorrhea, amenorrhea, and galactorrhea settled with the treatment but no withdrawal bleeding, readmission and having low AMH level and mild fluid in the pelvis. So what are the red flags in the case? Fluid in the pelvis. So does she have some outflow tract obstruction? That she is having the menstruation but it's not coming out. Then possibility of post-surgical endometrial damage because some undocumented procedure was done. But hysteroscopy is the gold standard to look for that. But in our society, it's a social dilemma to undergo a hysteroscopy at a tertiary care setup in an unmarried female. Or early ovarian failure because she was having some low AMH levels done twice. And that could also represent early phase or non-classical form of POI. That is primary ovarian failure or insufficiency. Or it could be temporary or reversible suppression secondary to OCPs that were given to her for the restoration of menstruation. So we further evaluated the case with repeat AMH levels and hysteroscopy was planned, and a multidisciplinary team team meeting was conducted, including endocrinology, gynecology, psychiatry, and radiology department of our hospital, because it was a diagnostic challenge for us that why she is not menstruating. A detailed informed consent was taken from herself and 2 family members, including her mother and eldest brother. Karyotyping was also done to exclude any form of mosaicism or any genetic disorder that we were missing that was normal. Then, to our surprise, the EO findings were uterus was small, rudimentary with atrophic endometrium, small cervix, and normal vagina. This was a real big surprise for us that what happened to her uterus. This EOA was done by the head of department of gynae herself. So endometrial biopsy report also came out as no endometrial segments. So her endometrium was missing and she was having an atrophic rudimentary uterus. So what happened to her? So we diagnosed her as hyperprolactinemia secondary to pituitary microadenomas and Asherman syndrome, the possibility of Asherman syndrome. So we further managed the case as we could just do the hormonal support in the form of cabergoline to control the prolactin levels, and psychosocial support was the most important thing at this level because a young unmarried female having a rudimentary uterus, that was a big challenge for her also. So the emotional impact of amenorrhea was addressed, and marriage concern and fertility implication. This is a literature review that's showing the Asherman syndrome after the uterine surgeries. Take-home message is, do not assume a single diagnosing, overlapping condition may coexist and require multidisciplinary management, and always consider a multifactorial etiology and involvement of endocrinologists before any gynecologic procedure is the take-home message. Thank you so much. These are the references. Okay. It's not working.
So this rudimentary uterus was not picked on ultrasound previously, on
Yeah.
MRIs and other things?
Exactly. It was missed. That's why it's a big challenge for us, because we done her MRI, and I have shown in the picture. Can I please have my presentation again?
And endometrium was thick.
Endometrium was
and
absolutely
later on it
normal.
became
Yes.
atrophic.
Endometrium was normal in imaging MRI brain, that MRI pelvis that was done in 2023, and we reconfirmed the findings again in 2025 from the head of department after providing her all the images that endometrium at that time was intact. So what happened to her uterus? That she underwent surgery at the very start for the initiation of menstruation, as I
But the
mentioned.
uterus was rudimentary. Probably.
Yes, that was found out at the EUA, examination of anesthesia, and not on the MRI pelvis. Because it can happen that uterus lining could be missed, or it could be synecdoche formations that can be missed on MRI. That's why hysteroscopy is the gold standard.
Why did you consider primary ovarian failure, FSH and estradiol
we
were
did not.
normal?
No,
The
we did not
differentials?
consider it. We considered that could be a possibility. That's why we repeated AMH after stopping oral contraceptive pills. And the reason for low AMH was possibly because of the oral contraceptive pills that we were giving her for the restoration of menstruation.
Okay, what was the reason of karyotyping investigation we did?
Yeah, the nice question. The karyotyping was actually advised by the gynecology team after the MDT that we conducted, and they were suspecting some rare form of Rokitansky syndrome or anemocysm of Turner that is being missed by us. So we respected their opinion.
Turner present with this primary
No, it-
amenorrhea with this
no.
sort of things if
No.
FSH and estradiol is normal.
Your question is very right, and that's why we conducted this MDT with the gynae team, and we respected their decision. And it was being done in after this long discussion with them. They wanted to be karyotyping to be done, so we respected it and we get it done.
What is your future plan for this patient? What did you guide her?
Yes, we planned her to keep a regular watch on her AMH levels and the estradiol levels, and till then, there's no need of any estrogen or estrogen therapy till her estrogen level falls. If she's suffering from POI, but we will control her prolactin levels, and we'll address her. We have addressed her marriage concerns and by involvement of the psychiatry team and her family, especially her brothers, because they were insisting her to get married, and that was the main issue right now. That's why she was suffering from severe depression also. Thank you so much.
Thank you, Dr. Iman Malik, for your participation in
I
this.
had a comment and question.
Sure, sir. I really wanted to have some insight from you.
Yeah, it surprised me, a patient with these symptoms and signs going to gynae so many times and they don't find an answer till they have done examination under anesthesia. You're saying MRI could not show a rudimentary uterus, it showed a normal uterus. In the MRI, ultrasound and CT scan of the pelvis, there are only two situations. Uterus is normal or there is no uterus. This
Yes.
is not a big thing. And the case evolved in so many investigations when everything was done because this information was missing.
Yes.
And if I give you a second scenario, if the uterus is normal and the way she is going through and the prolactin has been normalized by giving cabergoline, what will be your diagnosis?
Can I have your question again?
Uterus is normal
Yes.
and she's not getting periods despite
Yes.
whatever you are doing. So, and prolactin is normalized.
Yeah.
So then
That
what will
could
be the-
happen because microadenomas, they can suppress the pulsatile release of GnRH, and that could affect the HP axis and resulting in a persistent
For
amenorrhea.
how long? For how long? Prolactin has been normal.
But yeah,
There is something called in patients with psychiatric disorders, which is called central hypothalamic amenorrhea.
yes, okay.
So that I was thinking on that till you brought me the pelvic report and utera.
Yes.
That was a simple thing that it should happen, but very surprising. I always say you should always be in touch with the gynae, but if the gynae gives you those answers, I don't know where to go. Thank you.
Thank you so much, sir.
Thank you, Dr. Iman Malik, for your presentation and participation. Our next participant is Dr. Sajad Ahmed, Fellow Endocrinology, Polyclinic Hospital, Islamabad. Dr. Sajad Ahmed, please come on stage.
Bismillahirrahmanirrahim. Assalamu alaikum and good morning to all of my honorable judges, seniors and fellows. My name is Dr. Sajad Ahmed and I am a fellow trainee at Endocrine Department Polyclinic Hospital, Islamabad. So I will be presenting a very interesting case today. So I will start my presentation with a question from the audience that what is the finding in this image and what possible endocrine causes come to your mind after watching this image? Anyone can answer in the audience. Anyone? Okay. So I will start with my history. A 27-year-old gentleman resident of Tarnoor, Islamabad, presented with chief complaints of fracture of right forearm, including radius and ulna, and fracture of left leg, including tibia, after a minor fall in his washroom 2 weeks ago. So the patient developed above mentioned fractures just after a minor fall in his washroom while he was taking bath 2 weeks ago. After initial treatment by orthopedic and trauma surgeon, he was referred toward medicine and endocrine department for evaluation of possible secondary causes of these fractures. He has history of recurrent fracture and bone swellings since 2018. In systemic review, he has history of marked weight loss, however, no history of heat intolerance, tremors, palpitation, fevers, and night sweats. He has history of bone pain, swelling, and deformities, however, no history of joint stiffness, rashes, photosensitivity, and alopecia. He has history of polyuria and polydipsia, however, no personal and family history of diabetes mellitus, head trauma, surgery, or irradiations. He has history of on-off constipation, however, no history of nausea, vomiting, diarrhea, jaundice, abdominal pain, hematuria, and urethral discharge. No history of Hakimi medications, topical, inhalational, and systemic steroid use. He has mood swings, depression, irritability, and fatigue. However, no history of neurological deficits, headache, and visual abnormalities. No history of shortness of breath, cough, hemoptysis, and chest pain. He has normal libido, normal early morning erections. So in past history, the patient has a remarkable history of previous recurrent fractures after minor trauma. Right femur fracture in 2018, again followed by left leg fracture in 2020, and a bound knee amputation of right lower limb, which was performed for a bone tumor, the biopsy of which showed a giant cell tumor, which presented as a left knee swelling after biopsy report. So in family history, there is no significant family history of musculoskeletal diseases, no history of any familial malignancies and endocrine diseases. In medication history, there is use of on-off use of multivitamins and painkillers. There is no history of allergic reactions to any medication. In personal history, he has poor sleep, decreased appetite, on-off constipation, and no history of any drug addictions. He is a BA graduate, unmarried, belongs to lower middle class family, and currently unemployed due to his health status and dependent on his father for his day-to-day and health expenses. Coming toward examination findings, he was anxious and sick looking, lying on the bed with IV line attached to his left hand, plaster of Paris applied to his left lower limb and right upper limb. And he, as I mentioned earlier, that he has above knee amputation of right lower limb. His BP was normal, BP was 100/70, pulse was normal, regular, and low volume, and his temperature, he was afebrile, and respiratory rate was 22 per minute. Postural drop, weight, and height cannot be assessed to minimize manipulation and further fracture risk. So in examination, he has generalized clubbing in his fingers. There was a swelling of 2.5 into 2 centimeter on maxillary region of left cheek, which is non-tender, hard in consistency, and normal overlying skin. He has swelling of 10 into 8 centimeter around left knee joint, which was hard in consistency, non-tender with normal overlying skin. There is no thyromegaly, and he was clinically euthyroid. There was no steroid purpura, bruises, or striae. His stretch penile length was 13 centimeter, testicular volume 22 ml bilaterally, and tenor staging was 5, and his rest of the systemic examination was unremarkable. These are the laboratory tests of this young gentleman. Here you can see that the abnormal labs are colored as red. The calcium is 13.9 milligram per deciliter, which is quietly raised, and his phosphate was 1.3, which is reduced. Alkaline phosphatase was raised at 377 unit per liter, and his IPTH was also raised at 87 picogram per ml. Rest of the laboratory tests like vitamin D, RFTs, LFTs, remaining electrolytes, and his thyroid function tests were normal. These images shows his radiological images of the hands, upper limb, and skull. These images, there are multiple findings of, there is subperiosteal erosions more toward the radial side, in the prominent in medial phalanges. There is generalized osteopenia, and in the second image of the right arm, you can see there is a fracture of both radius and ulna, and plaster of Paris is applied. And the X-ray skull image is not that much good. The quality is not that much good, but still you can appreciate salt on paper appearance. These are the images of his X-rays of his lower limbs, which shows the expansile lytic lesions in the proximal head of tibia and the proximal, the distal femur. So his parathyroid scan report shows increased radio tracer uptake in the left lower pole of thyroid. That returns in the left set of images. Here in the images also you can see that there is a radio tracer uptake in increased radio tracer uptake in the left lower pole of thyroid. So there is scintigraphic evidence of parathyroid hyperplasia in left lower pole of thyroid. The previous bone biopsy reports for which that lower limb amputation was done shows the report shows that shows there is a giant cell ridge tumor. The one was performed was taken from the left tumor and the other was taken from the swelling of proximal tibia. The bone scan which was performed, this is also previous report. The findings are suggestive of osseous metastasis. There is increased radio tracer uptake in skull, medial end of right clavicle, and in lot of bone, in short. The ultrasound neck shows a well-defined hypoechoic mass posterior to left lower lobe of thyroid. Ultrasound abdomen and pelvis showed normal studies. There were no kidney stones. So the list of differential diagnoses include primary hyperparathyroidism with osteoporosis and multiple brown tumors, multifocal giant cell tumor, metastatic bone disease, aneurysmal bone cysts, and osteoporosis due to other causes. So these patients, based on the test and radiological data, he was diagnosed as a case of primary hyperparathyroidism, and he had severe hypercalcemia and managed with IV fluids and IV bisphosphonates, and after optimization of calcium level, he undergone parathyroidectomy after a few weeks, and the biopsy revealed parathyroid adenoma of 3.1 into 1.5 centimeter. These are the biochemical lab comparison at presentation following medical and surgical management. Serum calcium was 13.9 at presentation following medical management. It is 10.2, and after surgical management, it came down toward 8.1. IPTH was raised at 87. And after surgical management, it was 33.19. So there are multiple case reports in which these brown tumor are misdiagnosed as giant cell tumor. So these are the two case reports of which presented as swelling of humerus, upper humerus. One is 44-year-old man and the other was female. And wrong surgical intervention were done in both of these cases. So the message is very clear that this patient was misdiagnosed as a case of GCT, and surgical intervention was taken on the basis of histopathology report. So we cannot differentiate between giant cell tumor and brown tumors on the basis of histopathology and imaging studies. So the calcium profile must be performed before any surgical interventions in such kind of cases. And thank you. At the end, questions.
Thank you, very interesting. So the first message from the case, and very well presented, is that any bone intervention, I always worry orthopedics do even everything on the joints, bones, hip replacement, they don't check calcium. And with the new trend, they check vitamin D and give vitamin D, we still don't check calcium. So this was a big problem. The case is very well presented. So now you are sure that it was not the giant cell tumor.
Yes, sir.
With the histology reviewed? Yes. What did the review of the histology said?
Sir, it said that it was giant cell rich, the biopsy reports. But
even after the review?
Sorry?
The first time they misdiagnosed the brown tumor as giant cell tumor.
Yes.
They did the surgery. Yes. Now, was after looking at everything, this was a case of hyperparathyroidism.
Yes,
and the brown tumor is a possibility. The histology was reviewed. And no, the answer is still it's giant cell?
No, sir. His histology was not reviewed. These were previous bone biopsy reports. The data was previous. He presented to our department with the recurrent fractures. And the hypercalcemia was diagnosed there.
What was the age of patient?
25-year-old gentleman, yes.
So, young, not young, but otherwise, because he started his problem much When
Yes,
he
much
was
back in 2018. At
at
that
the
time,
age of
he must be-
18. So if you get hyperparathyroidism at the age of 18, what
Yes.
other things you should consider?
Sir, familial malignancies like men.
Not malignancies, other syndromes.
Syndromes, yes, sir.
Like-
men 1 and men 2A.
So did you investigate his family at least by doing calcium?
Sir, actually the problem was that they were from very poor background, and at that time we just we took history for pheochromocytoma, and we were not.
I'm not worried about pheochromocytoma. I'm worried about
His family
simple
members.
doing calcium. And for the young leaders like you who are presenting, look, the
Yes,
two things are different. My patient cannot afford it,
Yes,
but
sir.
I was thinking of doing it.
Yes, sir.
You didn't write, I was thinking of doing it.
Yes, sir.
So that means you didn't think about it. So if you, as I say, something not documented is not done. You say, I plan to do it,
I
but he
plan to
couldn't
do, yes.
afford it.
Yes, sir, we
So
will
that's a
plan,
message for
inshallah.
everybody. Thank you.
Yes.
Thank you, Dr. Sajad Ahmed, for your participation and excellent presentation. Our next participant is Dr. Soman Prithiani, who is working as for endocrinology in Aga Khan Teaching Hospital, Aga Khan University, Karachi. Madam, please come on stage in your presentation.
Assalamualaikum everyone. I am Dr. Suman Birsiani, endocrinology fellow at Khan University Hospital. So today I'm going to present a case of 22-year-old male diagnosed and being treated for primary adrenal insufficiency since the age of 5 years. He presented to endocrinology clinic as transition from the pediatrics care. So going back to his perinatal history, date of birth March 2000, birth weight 2.7 kgs, normal baby boy, achieved his milestones timely, was doing fine till age of 9 months. At the age of 9 months, he developed acute respiratory tract infection requiring bronchodilators and antibiotics, had recurrent chest infections and jaundice till age of 3 years requiring frequent outpatient visits. At the age of 3 years, parents noticed darkening of skin, sunken eyes, inability to weight gain, fatigability, and lethargy. So in July 2005, at the age of 5 years, patient admitted with acute hepatitis A, and here he was worked up for hyperpigmentation. Among his labs, morning samples of ACTH showed 1250 picogram per ml, cortisol was 3.0 nanogram per deciliter, aldosterone was less than 1.1 nanogram per deciliter. Creatinine and electrolytes were within the normal range. In hospital management, patient was managed on the lines of primary adrenal insufficiency with hydrocortisone and fluorocortisone. Coming to the family history, younger brother also diagnosed with adrenal insufficiency at the age of 3 years, and he was younger 3 years than his elder brother. He also had skin darkening since the age of 3 years. These are total 3 siblings, parents is no non-comorbids, and no consanguineous marriage. Personal history, he is single and currently moved to abroad for his bachelor's, and he has no any history of addictions. Among medication history, he is taking hydrocortisone 20 mg plus 5 mg in afternoon and fluorocortisone 0.1 milligram per day. So first outpatient visit in adult endocrinology clinic was in March 2022 at the age of 22 years. He was hemodynamically stable, weight was 69 kgs, height 166 centimeters, and making the BMI of 25. On examination, he had mild skin pigmentation over the oral mucosa and knuckles. Well virilized, genital examination was unremarkable, testicular size was 20 ml bilaterally. So over here, labs were ACTH was 155 at this time and renin was less than 0.5. He was taking treatment hydrocortisone 20 in the morning and 5 mg in afternoon, total of 25 mg per day, fluorocortisone 0.1 milligram. So here our impression looking at the familial history of the patient of primary adrenal insufficiency in both the brothers, we think about the genetic disorders of the glucocorticoid deficiency, questionable congenital adrenal hyperplasia, or the adrenal agenesis. So we decreased the hydrocortisone from 25 mg to 20 mg per day, continued and decreased the fluorocortisone half tablet per day. So we plan to look for the 17-hydroxyprogesterone, testosterone levels, electrolytes, and we considered for the genetic testing. So on subsequent follow-up visits in April 2022, after a month, testosterone was 544, 17-hydroxyprogesterone levels 0.08 nanogram per ml, ACTH was 731. He was taking hydrocortisone 20 mg per day. And electrolytes were fine. So we switched his hydrocortisone to prednisolone 5 mg, 1 plus half tablet. In the next follow-up after 3 months, his ACTH was 5.27 on delta cortical. Clinically, he felt lethargic, vomiting, decreased appetite and fever, examination hypotensive and tachycardic, hypopigmentation, and we referred the patient for admission for Addisonian crisis. So he was managed in the hospital on the lines of Addisonian crisis and got discharged on hydrocortisone 20, 10, 10 and fluorocortisone 0.1. Patient was lost to follow-up for around 8 months from August 2022 till April 2023. As we had advised genetic testing previously, so in April 2023, he presented with the genetic test report. Both patients are homozygous for the PER188C variant in STAR, with both parents being heterozygotes. So basically, this patient has a STAR gene mutation. So STAR protein is the one that has the role in the adrenal steroidogenesis pathway. Basically, it leads cholesterol from cytosol to the mitochondria, and further enzymatic activities occur for the aldosterone, cortisol, and androgen synthesis. So our diagnosis here is lipoid congenital adrenal hyperplasia non-classic. On further follow-up visits, in April 2023, ACTH was 1250 picogram per ml. Here, dose of steroids were hydrocortisone 10 plus 5. We advised ultrasound tests to look for the DARTs as patient has persistently raised ACTH levels. After a month, in May 2024, his ACTH levels 1000 picogram per ml. Here, along with hydrocortisone, we added prednisolone 2.5 mg at night. Then in August 2024, his ACTH levels 264, renin was 1.3, testosterone 330, electrolytes were fine. We continued with the same treatment, and this was the last visit of patient with us. After this, he had been moved to abroad. Ultrasound tests were normal except for the minimal left-sided hydrocele. So currently, patient is on this regime, and this is the latest report of ACTH 93 that has been done in the US. He is doing clinically well, has mild hyperpigmentation over the knuckles and oral mucosa. So learning points in this case is very rare case of non-classic lipoid congenital adrenal hyperplasia. Always think for CH in familial primary adrenal insufficiency as non-autoimmune cause of primary adrenal insufficiency. Referral of patients for genetic testing in such clinical presentations. So this is a case report. So this form of non-classical congenital lipoid adrenal hyperplasia was first enrolled in 2006. The objective of this study was to investigate whether non-classic forms of this condition do exist or not. So this is a similar study. This was a Pakistani family. Both children were 46XY, and they also presented at the ages of 2.5 and 4.5 years with the hyperpigmentation, raised ACTH levels, and never admitted with the salt wasting syndrome or such like things. So lipoid congenital adrenal hyperplasia is caused by homozygous or compound heterozygous mutations in the gene encoding STAR on chromosome at P11. The epidemiological data of lipoid congenital hyperplasia mutation has been repeatedly identified in specific ethnic backgrounds. So this rare disease is most common among Japanese, Korean, and Palestinian Arab population, that is classical lipoid CH. A milder non-classical form of lipoid CH was first described in 2006 and is caused by mutations that retain about 20 to 30% of normal STAR activity. So most of these patients carry the STAR mutation R188C, which has been found in patients from Canada, Jordan, India, Pakistan, and Thailand. However, other STAR mutations causing non-classical lipoid CH has also been described. Thank you.
It was an excellent case. I want to know why you added two types of steroids.
Ma'am, because of persistently raised ACTH, as patient was already taking the hydrocortisone, so we thought to add on the long-acting steroid at night to suppress the ACTH levels.
Okay, but once the patient was on the long-acting steroid and the ACTH was in the normal range, at that time patient developed Addisonian crisis. What was the reason at that time?
At that time, patient had developed infection as well. He has dengue fever. Yes.
So can we keep this patient on one steroid, or you want to keep the both types of steroid on?
For now, as we are looking for the response towards the ACTH, so if we see that 2 times patient ACTH has responded to adding on 2 steroids, hydrocortisone and delta-cortil. So we will follow the ACTH levels and the clinically hyperpigmentation, then we can taper on further.
Very good case, learning for me as well. Just maybe I missed or not. So it is CAH with normal 70 OHP.
Yes.
So this is a different, not the classical or non-classical. It's a different category, star type. The second question is in the management of Addison's disease or any other CAH related hypoadrenalism, do we rely on ACTH value to adjust the dose?
No.
So you are relying on ACTH value?
No, along with ACTH, the clinically patient is hyperpigmentation.
So now the patient
as
is
well.
clinically okay. So what will you decide about the dose?
So further
ACTH is never normal in these patients.
Yeah. So further we will decrease the dose looking at the clinical symptoms of the patient.
Thank you.
Secondly, a simple comment or message, the role of genetics. So it had made your life easy, I think, to diagnose, to further manage this patient.
Yes.
So the thing is that like, if you want add on genetics or anything new modalities, it makes the life of endocrinologist at least easy. Thank you.
Yes. Thank you.
Thank you, Dr. Soman, for your participation and presentation. Our last participant is Dr. Usama Ahmed Ansari, who is working as fellow endocrinology at Jinnah Postgraduate Medical Center, Karachi. Dr. Usama Ansari.
Assalamu alaikum everyone, I'm Dr. Usama Ansari, fellow endocrine from JPMC. Today I'm going to present you a very interesting and fascinating case, 3 of a kind, a rare familial enigma. Let's begin this journey. My patient is 20-year-old male, resident of Concord, Sindh. He presented to us with complaints of generalized hyperpigmentation for last 6 years, dysphagia for last 1 year, weakness of both hands for last 8 months, and grittiness in both eyes for last 2 months. My patient was all right 6 years back when he developed progressive diffuse darkening of skin involving palmar creases, knuckles, elbows, oral mucosa, and tongue. There was progressively worsening dysphagia, initially for solids, then followed by liquids with occasional non-bilious vomiting and episodes of choking, especially at night. There was progressive weakness of both hands with difficulty in gripping and executing fine motor tasks. My patient also had history of frequent episodes of redness, grittiness, and photophobia of both eyes. Notably, there was intermittent abdominal pain without any relation to food intake. He had unintentional weight loss, episodes of dizziness, nausea, and fatigue. My patient did not have history of fever, night sweats, and productive cough. There were no autoimmune features like dry mouth, joint pain, swelling, morning stiffness, or parotid gland swelling. There were no episodes of mucocutaneous candidiasis or any features of hypoparathyroidism. My patient denies school difficulties, low IQ, delayed milestones. He had no significant drug history. There was no past history or family history of tuberculosis. So this is family pedigree of my patient. The index case is 20-year-old that is suffering from the constellation of symptoms I just mentioned. His brother is 11 years of age, and he is also affected with a similar clinical picture. He has diffuse hyperpigmentation, and most recently he has developed eclasia. One of his brother died at the age of 9 years. due to hypotension and hypoglycemia, but his case was undiagnosed. Two of his brothers and sisters, they are clinically asymptomatic. Parents are had consanguineous marriage, and they are healthy. On examination, cachectic pale-looking male with temporal hollowing and wasting, with BMI of 14 kilogram per meter square. His blood pressure was 100 by 60 millimeters of mercury with orthostasis. There was conjunctival hyperemia on eye examination. There was diffuse hyperpigmentation involving lips, tongue, buccal mucosa, and skin folds. Neurological examination reveals bilateral wasting of thenar, hypothenar muscles with clawing of fourth and fifth finger. Deep tendon reflexes and sensory examination was unremarkable. Rest of the endocrine and neurological examination was also unremarkable. So this is my patient. There is diffuse hyperpigmentation, wasting of thenar, hypothenar eminences, and clawing of fourth and fifth finger. This is his brother. He's 11 years of age. He also is having diffuse hyperpigmentation, and there is wasting of thenar and hypothenar muscles. So on the basis of my history and examination, I have kept certain differentials, starting with primary adrenal insufficiency, autoimmune polyglandular syndrome, Sjogren syndrome, familial glucocorticoid deficiency, and L-groove syndrome. So I started off with the basic blood test. My patient was found to be anemic with hemoglobin of 12 milligram per deciliter. Rest of his electrolytes, calcium, HbA1c, ESR was all normal. His RBS was 100 milligram per deciliter. His hormonal workup shows morning cortisol of 0.07 microgram per deciliter. ACTH was markedly elevated. It was 1200 picogram per mils. Plasma renin, aldosterone, and TSH was normal. His chest X-ray was unremarkable. Sputum for AFB smear and gene expert was negative. IGRA was also negative. His autoimmune worker was also negative. Okay, so we did imaging test. CT chest and abdomen was done that shows dilated esophagus with air fluid level, raising the possibility of eclasia cardia. Adrenal glands appear grossly unremarkable, aligning with ACTH resistance. His upper GI endoscopy was done, which shows dilated sigmoid shade esophagus with puckering of gastroesophageal junction, and there is erythematous mucosa. Ocular investigations include slit lamp examination that showed conjunctival congestion, corneal dryness. Tumor test was positive with wetting at 5 minutes in right eye 4 millimeter, left eye 3.5 millimeter. Nerve conduction study shows bilateral ulnar motor neuropathy with no sensory involvement. So I discussed this case with a genetician, and he was of opinion to get genetic testing done to confirm the diagnosis and identify carriers in the family. However, due to financial constraint, the family declined genetic testing. Final insights to putting it all together: ACTH-resistant adrenal insufficiency, alacremia confirmed by Schumer test, eclasia evident on CT chest and endoscopy, motor dominant peripheral neuropathy, ulnar involvement, clawing, positive family history with consanguinity and affected sibling, making it an autosomal recessive disorder. So I have come to my final diagnosis of L-groove syndrome. It is basically a rare autosomal recessive disorder. It is characterized by the clinical triad of ACTH-resistant AI, eclasia, alacremia. 1/10 patient develop neurological and autonomic dysfunction. Prevalence is 1 in a million, making it so rare. Caused by mutations in the AAAS gene on chromosome 12. It encodes the eledin protein. So management includes hydrocortisone 10 mg at 7 a.m., 5 mg at 1 noon. Esophageal dilatation was performed by the gastroenterology team, after which his dysphagia markedly improved. Artificial tears was advised by the ophthalmology department. Physiotherapy was advised for hand muscle wasting. Proper education for stress dose and sick days management was done. Psychological support, nutritional rehabilitation was offered. Genetic counseling was offered, however denied. Medic alert bracelet was strongly advised. So I did some literature review. So there is a case of 18-year-old male from Syria. It was published in Annals of Medicine and Surgery in December 21. It is an 18-year-old male who presented with recurrent episodes of postnatal conjunctivitis, who was diagnosed with alacremia since birth. At 7 years, he started having dysphagia, for which he was being investigated and found out to be eclasia, upper GI endoscopy. At 18 years, he was diagnosed with weight loss, generalized fatigue, generalized pigmentation, for which his tests were done, and he was diagnosed with adrenal insufficiency. So based on these findings, he was diagnosed as Algrove A syndrome. And most recently, he's developed muscular atrophy in foot and peripheral neuropathy. Another case report of an 18-year-old male who presented with adrenal insufficiency. He was born of a consanguineous marriage as well, like in our case. His younger brother died at age of 1 year with possible adrenal insufficiency. Rest of his siblings were normal. So he had normal electrolytes, cortisol was very low, 0.41 microgram per deciliter, ACTH was raised. He was then later diagnosed with alacremia, eclasia cardia, and subsequently external peripheral neuropathy, and the diagnosis with Algrove's was made. Genetic testing could not be done. So in endocrine, it is sometimes important to connect the dots. Thank you so much, everyone.
Thank you. It was really a very good case, and I congratulate you and your team to be able to make the diagnosis. It is a detailed history and everything which made it. What is the long-term management and prognosis for this case?
Okay, so we do need to monitor these patients for long-term, like we'll be having a multidisciplinary approach for this patient. We'll be following up with his cortisol levels every 3 monthly, and also his general conditions like his weight gain.
Cortisol is easy for endocrine to management.
Yes.
What about the eclasia, alacremia, neuropathy, and muscle wasting?
Yes, sir. For eclasia, he needs to approach gastroenterology. We need to take that on board because he might be needing regular dilatations, because we have seen in the literature that these patients tend to have repeated congestion of esophageal. They need to have that esophageal dilatations on multiple occasions. Similarly, with ophthalmology, 6 to 12 monthly follow-ups, and he has been advised artificial tears and artificial gels. There is another case report in which these patients tend to have progressive neurological degeneration. So we need to keep a close follow-up on these patients. We need to take neurology on board, and we need to see the symptoms that are developing in these patients.
What advice will you give to the family in future?
Okay, so as it's an autosomal recessive condition, and there is 25% chance of getting the disease, 50% chance of being a carrier. So we need to, we can give advice for like future prenatal counseling, but the patient is from a very poor setup. So, but we will advise for chronic villous semitting and pre-implantation natal diagnosis, so we can correctly incorporate the embryo which is unaffected for future pregnancies. Thank you so much.
Thank you, Dr. Osama, for your participation and presentation. There is no failure. You either learn or you succeed. Do your job, then let the judges decide. It was a very fascinating event, and thank you all participants for your presentation and participation. Before taking the final result in the winner, we will take the comment of our worthy panelist, Professor Dr. Abdul Jabbar. Sir, please to have your comment about this event.
I think this forum is excellent. It is a great opportunity for young fellows to present. I'm sorry I'm a bit tough, but that's the whole exercise for others to be prepared when they come next time. But I think we learned ourselves a lot, and this forum is giving a good opportunity. Congratulations to the team, PES, and everybody, and to the fellows. It's always, everybody is a winner, whether you are first or last, doesn't matter. You were bold enough, prepared enough to present in front of the forum and the audience. This is an excellent learning exercise. Thank you.
Associate Professor Dr. Ibrahim Ahmed, sir, please have your comment about the event.
The start of activity was on low pace. Now it's a regular activity of
Yes,
our
sir.
midsummer. Secondly, with this activity, we are able to make give some confidence to our fellows to come and go to the podium and get some good manners and something like that. So that so just to add
Keeping
on,
them in line and discipline,
just
yes,
to
sir.
add on that, do an advice to the supervisor that they do prepare their students before giving them the chance to go to the podium. There are how to tackle the questions, how to answer them. This is the basic thing we are lacking. And in the end, thanks to PES and thanks to President that she's continuing these activities in future, or thanks to Endohub team to fully incorporating these things.
Yes, sir. Very well
And
said. Thank you so much, sir.
At the end, the gets farm also.
The Gates Farmer. Thank you, sir. Dr. Sadia Salman, please, any comment you want to add to this event?
I must say every candidate has done a great job. Excellent cases, excellent presentation, and effort of candidate as well as the supervisor. So I want to congratulate the candidates and the supervisor. They have done an excellent job. Everything was done very well.
Sir, please have your comment about the
Bismillahirrahmanirrahim.
event.
Assalamu alaikum, everyone. I'm really happy today to have the hall full, and the audience were listening very enthusiastically. And I congratulate all the fellows and their supervisors. It's really a great opportunity to learn, interact, and to present their cases in the presence of all prominent endocrinologists and doctors and physicians. So once again, I congratulate PES, Endohub, and Gets Pharma. Thank you.
Thank you so much for your kind comment. For the certificate distribution, I would like to invite two persons, Mr. Agha Sadiq Mirza and Shayan. Please come on stage and join us for the certificate distribution from Gates Pharmaceutical. We will start our certificate distribution ceremony from the panelist.
क्या करना है? Announce करना है?
जी sir.
Here are the results of this price क्या है? Price क्या है? अच्छा one first. As tradition, this after this good presentations, number third is Dr. Sajjad from the score of 74.17 in. Dr. Osama Ansari, the number second, score of about 78.13. And the winner is always who had done some genetics or something else like that. Dr. Suman from 83. And आप तीनों आ जाएं. And for Dr. Suman, there's an ACE MENA registration. इस तरह ही है ना, from Gets Farms.
Professor Dr. Abdul Jabbar.
Dr.
Sir,
Aisha, Dr.
please join
Tahir
us.
और Dr. Umar आ जाएं. हम भी आ जाएं. हम भी आ
S- s- Sir, please be. We will call certificate distribution ceremony for Endohub faculty. The first one, Dr. Dr. Sidra Aludi, please, madam, come on stage and join us for the certificate distribution ceremony. उसको दे। Dr. Sidra Aludi. Dr. Shaila Tabassum, if anyone can receive on behalf of her. Dr. Kaleem Badini. Dr. Sulaiman Ilahi. Dr. Sumaira Batul. Dr. Rab Nawaz. Dr. Gawar Khan. वो चले गए बस ठीक है बस बाकी हाँ हाँ हो गए Thank you so much. This was a wonderful event.